Okay, thank you, Dr. Rashini Verma, once again for the very kind introduction about me. Welcome to all of you for this AFOMP school. It's a webinar number 2, I understand. All right, so I would like to request Dr. Ginny Wong to show her slides, and then I will introduce the speakers for this. Can we go to the very first? Yeah, all right. So this webinar, we have the ACP, SEM, the CPD endorsed. So we have received certificates, attendance. So the theme is patient dosimetry in diagnostic radiology, a very broad view. We just focus on the basic radiation dosimetry. There will be delivered by Associate Professor Dr. Ginny Wong. And then I will talk about the patient dosimetry in general radiography, then followed by Dr. Mohd Khalis on the patient dosimetry in CT. So we can't cover the other aspects such as in mammography, fluoroscopy, intervention radiology. Perhaps we can do that as a part 2. Next. Okay, Dr. Rashini has introduced me. We just skip that. Our first speaker is Associate Professor Dr. Ginny Wong. She is a PhD from University of Wollongong, Australia, and she basically her research interests cover radiation dosimetry, the radiation detectors, advanced detectors, and also radiomics. Federation of Medical, and also she received several awards from the service from 2001 to 2019. So she also has published lots of papers in various fields in medical. Okay, sorry, just interrupted. So the next speaker. Hello, Dr. Jenny. Can you turn to, okay, is Dr. Mohd Khalis Abdul Karim. She's a senior lecturer from the Department of Physics, University Putra, Malaysia. She also has a very good background in radiation physics and also radiation dosimetry. His research interests also extend to medical imaging, in image processing. He also has received from the, it should be the University Chancellor Award, Excellence Award from the Ministry of Health and the University Putra of Malaysia. So he also has published lots of papers in this area. Okay, so the format will be the 3 speakers, Associate Professor Wong, and then me and Dr. Mohd Khalis. So we will go through in that sequence, and then please key in your questions to the chat box, and then we have the question and answer towards the end. Okay, so let's now pay attention to Associate Professor Dr. Wong to start off with the webinar.
Okay, thank you, Prof. N. Just let me.
Before starting, I want to request all the participants to please switch off their videos and mics for better bandwidth and smooth performing of functions.
All right. I hope everyone can see the slides. You can hear me well? Okay, thank you, Prof. Ng, and thanks to AFOMP to give me this opportunity to give this talk in this webinar school. And so I'll be covering the basic of the radiation dosimetry. So to start it off, I would like to just mention that as we are aware, with more and more resources being made available, with more and more advanced medical imaging technology, we are seeing a trend in the global annual number of medical radiological examination and procedure increasing over the years. This is from the ANSI report 2020-2021. So it means that the radiation burden to the population, to the population is increasing. And why do we need to do dosimetry imaging? Now, while we are well aware that dosimetry and QCs in general are integral part of radiotherapy delivery, but dosimetry imaging doesn't have such an emphasis. Mostly they're used for radiation protection purposes, shielding, and so why is this indifference? Is it because that it's less dose, lower dose, or is it because there is a justification for the imaging? So do we need to do dosimetry imaging? And on top of that, do we need to do patient dosimetry? So I would like to try to present this, that we need to do dosimetry in diagnostic imaging because we need to quantify radiation dose so as we can provide better diagnosis, leading to better treatment management. To be able to determine and quantify radiation risk associated with the imaging, to optimize imaging and intervention procedures. And if you are involved in setting up diagnostic reference level in your department, this is also a crucial part. We want to reduce patient dose and to avoid overexposures. For pediatric patients, where their tissues are generally more radiosensitive and they have a longer lifetime, increased radiation exposure would lead to an increased lifetime attribute risk of radiation to do and induce secondary cancer, as well as the merging of discipline. We are seeing more and more KV beams being used in imaging for IGRT in radiotherapy. So in radiology, interventional radiology procedure has also become more and more common to treat various vascular and cardiac diseases. And as the treatment techniques become more and more complex, the treatment time, the radiation exposure to patient and staff are also increasing. This is also one of the procedures that could likely induce reach doses that could induce tissue reaction in the skin, as well as in the eye lens, which is radiation-induced cataract. In 2011, the ICRP has revised their threshold dose for radiation-induced cataract formation to 0.5 of gray from previously 2 gray. This also led to recommendation to lower annual equivalent dose limit to occupational dose, the equivalent eye lens cells from 150 millisieverts to 20 millisieverts a year. So there are also implications to the occupational dose as well. So I hope that I have convinced you that there is a need to do radiation dosimetry in diagnostic imaging. So what next? That dosimetry in diagnostic radiology, this document from IAEA TRS 457 is an excellent document to guide us on dosimetry in diagnostic radiology. In this document, it presents the dosimetric quantities and units and dosimetry formalism, the instrumentation needed, as well as the code of practice for clinical measurements. And many of the content of this talk, this webinar, are taken from this source. Now, before we start, I would like to say that when we want to do patient dosimetry, we need to ask these few questions. First, what is the need? What is your purpose of doing the dosimetry, patient dosimetry? Which modalities that you're thinking of? What do you want to measure? What's the radiation quantity that you wanted to measure? What are the resources and tools that you have in your department to do this? And then finally, the methodology. I will expound on each of these one by one. This picture here shows a diagram interlinking the 4 questions that I have asked just now. So the purpose and the modality will dictate what type of radiation quantities that you should be using. And of course, that's also closely linked with what are the tools that you can use to do this. You know, if you don't have certain tools, you can't try measure certain quantities. Or if you have certain softwares that you can use, then you can use certain other quantities. The methodology follows it as well. So the first question, what is your purpose for doing this radiation dosimetry in diagnostic imaging? Is it for QCS of machine, constancy output? Do you just want, is it for regulatory requirement? Did you want to do patient dose monitoring? Is it a specific focus in investigation? Is it for optimization? Did you want to do radiography equipment performance tracking? Or is it to know what's the radiation risk and tissue reaction estimation? So this is crucial so that we can know what's the suitable radiation quantity, what's the appropriate radiation quantity to use, and feasible and logistically practical. The TRS 457 outlined the radiation quantities that is suitable, that is used in diagnostic imaging. It divides it basically into 3 categories for the basic quantities, which covers fluence, energy fluence, Kerma rate, absorbed dose, exposure. Then it also covers a range of application-specific quantities, such as incident air Kerma, SARC, KAP, CTDI, DLP, and the risk and tissue reaction quantities, such as organ dose, MGD, mean glandular dose, equivalent dose, and effective dose. So I will be covering in my lecture talk today, I'll be covering most of the basic quantities and a couple of the application specific quantities, but Prof. Ng will explain more on the details of these application specific quantities, particularly for general radiography, as well as Dr. Khalis will be talking more about CT. These quantities, for example, will also, like radiation risk and tissue reactions, are usually suitable in terms of when you want to convey information to a certain a group of people, whether it's radiologists, your colleagues, whether it's the patients, patients' parents. Yeah. So we'll move on and start with the first part, which is radiation quantities. So I would say that it is important to understand the radiation quantities and what it is actually being measured. So the following few slides will be covering quantities that are described in this diagram here. So we have the X-ray source, X-ray coming out. These lines are representing the fluence, energy fluence, and these are scattered radiation from the patient. So starting with fluence. Fluence is basically the radiation rays that's coming out from the X-ray source, and fluence are the expectation value of the number of rays striking a finite sphere surrounding a point P. So if you imagine, if you are measuring here at this point here, and there's an area, so your detector will have an area. So fluence are basically like the rays that passing through that, right? So the units are per centimeter or square. Energy fluence takes into account the energies of each and every one individual X-ray, the rays. So as you know, X-ray is a spectrum of radiation, photon beams from low energy to high energy. So each photon, each fluence has an energy that's associated with it. So therefore, energy fluence is basically talking about this, the photons and their energy associated with it. So the unit is joule per meter square or joule per centimeter square, etc. Kerma, also, it's short for kinetic energy release per unit mass, Kerma. So it is basically the total energy transferred to charged particles, the secondary particles in the material, the medium, where the X-ray impinge on. And by indirect ionizing radiation, X-rays, gamma rays, and neutrons. So Kerma is only related to indirectly ionizing radiation, not charged particles. The unit is joule per kg or Gray, and we use the symbol of K. So Kerma is defined for each material. So if you measure here in air, then you're measuring Kerma of air. If you measure in water, you're measuring Kerma of water. If you can measure in PMMA, you're measuring Kerma in PMMA. Yeah? Kerma generally have two components, which is the collision Kerma and radiative Kerma. This is what it describes the kinetic energy of these electrons that are spent in two ways. Collision Kerma is the Coulomb force interaction with the atomic electron of the absorbing material that resulted in the dissipation of energy in the material or in the tissue. So that's the absorbed dose in tissue, and this is what we care. Radiative Kerma are the radiative interaction with Coulomb field, the atomic nuclei, which results in stratum, and the energy can be carried far away from the track. And it can, well, leave the body, and we don't care. But in diagnostic radiology, most interactions are in collision Kerma. There's very little radiative Kerma. Kerma can be related to energy fluence via the mass energy transfer coefficient here, which is a function of the photon energy and the atomic number of the material. Collision Kerma, on the other hand, is related to the energy fluence by the mass energy absorption coefficient. Next, we'll talk about absorbed dose. Absorbed dose is defined as the energy deposited per unit mass of matter. This unit is relevant, this quantity is relevant to all types of ionizing radiation, whether X-rays or gamma rays or charged particles. This quantity is useful because we often use it to relate to effects in matter, tissue reaction in matter, the stochastic effect, those deterministic effects. The unit is same as the Kerma, which is joule per kg or Gray, but the symbol we will use D. Another quantity that is important in X-rays dosimetry is exposure. It is defined, well, a lot of time we talk about exposure in a very layman term, about radiation exposure, but in our field, exposure has a very, very specific definition, which is the number of charge, whether it's positive or negative, created by radiation in air, a mass of radiation in air. This is only relevant to X-ray or gamma ray. So the O unit is Frongen, and while the SI unit is Coulomb per kg. So imagine you have your ion chamber here, and what you're measuring is exposure. Okay, exposure is essentially the ionization equivalent of collision Kerma in air for X-rays and gamma rays. Now, while we are talking about exposure, a very important parameters that we need to, variables that we need to talk about is this W, which is basically the mean energy expended in gas per ion pair form. So this unit for X-rays and gamma rays in dry air is very well quantified to be 33.97 EV per ion pair. Means that you need this much of energy, 33.97 EV, to create one positive ion and one negative ion in air. And of course, we can convert this to joule per kg using the electron charge. So why I mentioned this? Because I'd like to point out that these three units that we just mentioned, the exposure, the kerma in air, and the absorbed dose in air, are interrelated. They are connected by this relationship, by the energy expended needed to create this ion pair. Okay. Now, how do we relate what we measure in air to in tissue? So this graph here shows the ratio of the mass energy absorption ratio between any material divided to air. So this relationship makes radiation dosimetry easier because we can relate the ratio between the mass energy absorption ratio between tissue and water to air to get the kerma in the tissue. For kV, for megavoltage energy range, it is very nice because they're very constant. However, it's not so, it's a bit tricky in the diagnostic range. As you can see here, because for different type of material, for example, higher atomic number material like bone, you get more enhanced response due to the photoelectric effects at low energy in diagnostic. So the same amount of exposure will not result in the same amount of energy imparted in the bone and muscle. So this is something that we need to take into account when we're doing dosimetry in diagnostic in energy range. So when do we use them? Exposure is usually used to relate to ability of photon beams to ionize air. What we measure in our ion chamber in air. Kerma or air kerma, they are more general and they are recommended for dosimetry calibration purposes. And absorbed dose is usually used to indicate effects of radiation in humans. I will quickly mention two application-specific quantities. I will not go in detail because Professor Ng will be going into details about this. So just to complete the story about why once we have kerma and absorbed dose and exposure, why that is not enough. Because diagnostic X-rays are very low energy. And when we want to measure patient dosimetry, we want to do patient dosimetry. If we try to measure radiation dose at the surface, no. Okay, if we want to measure in air, then we're actually measuring air kerma. Now, if we want to measure dose to patient, if we want to measure absorbed dose, we have to stick our ion chamber in the patient, right, to measure absorbed dose. But that's in practicality cannot happen. So the closest that you can do is to have your dosimeter on the patient. And that's why it's not sufficient to have kerma and absorbed dose only. So we need to have other special application-specific quantities like incident air kerma and entrance surface air kerma to describe what is what is happening at the surface of the patient. So incident air kerma is the kerma to air from an incident X-ray beam measured at the central axis at the position of the patient or phantom surface here. However, this quantity only includes radiation incident on the patient or phantom, and no backscattered radiation is included, because as you can see, when the radiation impinges on the patient, there's always scatter, and some of this scattered radiation may reach the detector. The unit for this is joule per kg or gray. as well. Entrance surface air coma is quite similar to incident air coma, but with the inclusion of the backscattered radiation. So, which is this? The backscattered radiation is a function of the field size, the half-value layer, the beam energy, and etc. So, a quick question. How do you know if you're measuring incident air coma or SR? So if you have a patient and you put a detector, you put your detector on the patient and you're measuring this, how do you know whether you're measuring incident air coma or SR? Well, the answer lies in what type of detector that you use. Yes, so someone, Mohd has said that if detector is laid back, it's incident air coma. Thank you very much. So yeah, that's exactly right. So it depends on the detector that you're using. And like if you are using this type of solid state detector where they have a lead back, that means the backscatters are blocked and they are not able to reach the sensitive volume of the detector. So therefore, even though you put this detector on, say, on the phantom or on the, you are measuring the incident air coma. But if you have other things like ion chambers and that doesn't have this lead back, or OSLDs or TLDs, putting on the patient, then these detectors will likely to be able to capture the backscattered radiation, and therefore you need to consider that what you're measuring at that point is entrance surface air coma. Right, so thank you. Right. So the next quantity that I'll briefly mention is the air coma area product, which is usually measured at the collimator at the X-ray output, tube output, if your radiology equipment has a KAP meter attached. Not all radiology equipment has this, but if you do have, then you will be able to measure the KAP meter. You can also measure KAP. You can also measure KAP at other distances with another ion chamber as well, provided you take into account the area of the X-ray exposure. So it's basically air coma is coma times the area of it. The units are gray, centimeter square, or milligray, centimeter square, or it can be very, very different, like centigray, centimeter square. So when we use this quantity, one need to be very careful about what's the unit, because every vendor may be different. So you can't just look at the value and compare them across straight. Oops. So one of the nice things about KAP is that it's distant invariant. So you can measure them at different distances, because as you go further away, the dose will reduce, like inverse square distance, but the area will increase, will double. So as long as you're able to know what's the area, then you can actually compute the KAP. Okay, with caveat, of course, that you shouldn't be having it too close to the phantom or the patient to capture the backscatter radiation. Moving on to quantities that's related to stochastic and deterministic effect. So these are quantities like organ and tissue doses, mean glandular doses, equivalent doses, and effective dose. Between all of this, the effective dose covers all the organs in the body, whereas the organ specific are just specific to the organ. This quantity is most relevant, a useful quantity to convey to patients, to health workers, and to radiologists. So organ dose is when you have the X-ray coming in and that's your organ in there, and if there's a particular organ that has interest, then you can you can do this in phantom if you have phantom, anthropomorphic phantom, and you can put detectors in there and you can measure the absorbed dose in there. Okay, organs that are more commonly require individual dose determinations are like skin, uterus, and lens of the eyes. It is important to note that organs may not be uniformly exposed all the time, that at times they are partly exposed, so the dose may be not homogeneous. So sometimes it is important to determine the organ dose, consider the mean absorbed dose and the maximum absorbed dose. The assessment of the absorbed dose to the most exposed area of the skin is essential in interventional radiology because the possibility of the complicated procedure may exceed the threshold for deterministic effect. So knowledge of the skin dose will be useful during the procedure so that it can be reminder for the operator to be mindful of the dose received by the patient and to avoid deterministic effect or reduce their severity, and after the procedure to have an appropriate management of the patient later. Mean glandular dose is, mean dose to the glandular tissue of the breast. This is of concern because these tissues has been known to have the highest risk of radiation-induced carcinogenesis. However, it's not a direct measured quantity, it's a derived quantity. So what you need to do is you have to measure the incident ACMA, and then you have to multiply with a few conversion coefficients, which takes into account the breast density, or make an assumption of the breast density, the beam energy, the target filter combination used, the breast thickness of use. Next quantities that we'll talk about is the equivalent dose, which proceed from the absorbed dose. It's taken from the absorbed dose, but it accounts for the different types of ionizing radiation. So that is called the radiation weighting factor, because to account for the different stochastic effects and the different magnitudes of the effects of the radiation dose to the tissue. Effective dose is following this, where we consider the different radiosensitivity of the tissues involved, which means that one grade of absorbed dose does not necessarily have the same risk wherever it is delivered in the body. So what we do is we take the equivalent dose multiplied by the tissue weighting factor and sum it all up for all the different tissue. So the first method is this, which is basically apply tissue weighting factor and sum them up and finally arrive on one single quantities. The second method, which is more relevant to CT, which they apply a certain conversion factor F. This, I believe, Dr. Khalis will explain more later. The ICRP, publication 60, which is later superseded by publication 103, details the different tissue weighting factor. So between these two publications, there is some changes in this the tissue weighting factor identified. For the gonads, they have reduced the weighting factor because studies has found that the gonads are not that radiosensitive as we think, whereas breast, the tissue weighting factors for breast has increased quite a lot, saying that the breasts are more radiosensitive. So effective dose is a convenient unit that allows us to combine a range of non-uniform tissues and organs dose in a single number that can be used to represent the risk to the health of the irradiated person. So regardless of the wide different dose equivalent received by the organs of the body. But to do this, it can be quite laborious if you do not have a software to do this, or if you intend to measure using dosimeters. It's possible, but it's quite a laborious process. Having said that, it is one useful quantity to compare the risk from health, also from different types of examination as well. So next, we'll talk about what are the tools and resources that you have. Now, what I meant is that I'll consider tools like dosimeters and phantoms. So if you have dosimeters, suitable, appropriate dosimeters and phantoms, you can do direct measurements. If you don't have these, but you have things like dose tracking software or dose estimation software, you can do an indirect method of estimation of dose. What type of dosimeter? For example, you have ion chamber. If you have ion chamber, depending on the modalities, you might, like if a mammo, you might need this type of chamber. If a fluoro, an X-ray, you would need this type of chamber. Or you have solid state detectors or TLDs or TLDs and OSLDs or films. So all can be used depending on what you have in your department. In terms of phantoms, you can use a large different range of phantoms. So if you have solid phantoms, perspex are very convenient to use. Even water phantoms, boxes of water, very simple. Or application-specific phantoms like the CDRH phantom, the CTTI phantom, the anthropomorphic phantoms. If you have one, they'll be very convenient if you want to be able to put in dosimeters in different locations to look at to simulate those to the organs. And of course, for those who are using the mathematical model, the Monte Carlo simulation, they will use mathematical phantoms. Dose tracking software, they are really useful to extract exposure and dose parameters from imaging system automatically from DICOM radiation dose structure report, RDSR. So however, so there's quite a few commercial systems available, but they can be quite expensive. So this is something that not all departments will have. But those who have, they will find it very easy to extract those parameters from the machine and to do things like DRLs and optimization using this type of quantities. Those estimation softwares and toolkits such as code that are useful to estimate dose to fetus, NCI dose, NRPB, these are various software. Some of them are free, some not, but if you have on your hand some of these softwares and toolkits, that can be really handy because you may not have to measure the dose, but you can actually do a fairly good estimation using these softwares. So what's the methodology and how to measure it? Again, I'll refer you to the TRS 457 for the application-specific dosimetries, the methodology and the instrumentation needed. But a recent paper published APM report, TG191, also report on the clinical use of luminescent dosimeters or TLDs and OSLDs, which I find it very, very nice and very comprehensive because it also details about how you can start and how you can manage a dosimetry program using these relative dosimeters. Key things to note when we look at this methodology is that what are the dosimeters used for each methodology, because each type of dosimeters are specific and there are uncertainties involved in the different types of dosimeters. Some may be easier, some may easier than the others, but also depending on the cost that you have to do it. Also the logistic and feasibility of you to do a patient-specific dosimetry. Just a few examples. For example, if we're measuring entrance surface erythema here, according to the TRS 457, this is the setup that you need to do. You have an ion chamber, and you have a phantom here, and you need to use the phantom to enable the AEC to work, to simulate more real light patient exposure setting. You need to record the dose and correct for the temperature and pressure, etc. for the ion chamber. You also need to record for the distance, the detector to the table, and apply the inverse square correction when needed, and need to measure the half value layer to know what's the beam energy. But what you really get here is basically you have a good simulation patient and the dose that would be resulted from that. You get your kVp/ms field size, and then you measure your incident air kerma. But in order to get entrance surface air kerma, you need to apply the backscatter factor. Okay. Example 2, if you want to use TLD and OSLD, you'll be able to put them directly on the patient surface, and they provide direct assessment of the patient dose. And this is already entrance surface air kerma. It's quite simple to carry out. However, they are usually larger uncertainties. So you need to be able to have in place appropriate handling and correction for this dosimetry. So, and again, I will refer to the two documents, the TRS 457 and the APM TG 191 report. And example 3, if you want to use indirect method, where if your machine have a KP meter installed, then you can consider to measure the air kerma area product from the KP meter. Logistically, is simpler. And you can also use this to establish DRLs and dose tracking activities. And when you do this, you can do this manually, but if you have some kind of dose management software, they can be quite helpful. This is my last slide, and I would just like you to just leave you with this slide where showing the intricate relationship between the 5 questions that we talked about just now: the purpose, the modalities, and the radiation quantities involved, the tools that you have, which leads to your choice of your quantities and the methodology that you use with it. Thank you. And I'll be happy to take any question later. And this is my contact. If you're welcome to email me for any questions. Thank you. And I'll pass it back to Professor Ng.
Yeah, thanks very much, Dr. Wong. Now, okay, have you stopped sharing?
Yes, I have stopped sharing.
Okay, then I see works or not. No problem. Can you see my screen?
Yes, we can see the screen, but try to do full screen.
Wait, there are a lot of things popping up. All the people ask questions. Now, what do I do now? From beginning, right? Is it moving?
No.
Can you see patient
Yes,
dosimetry in general radiography?
Yes.
Okay, good. It's working. Thank you very much. Dr. Wong has really given us a very good introduction to the basic of radiation dosimetry related to patient dosimetry. Fundamentals are very important. In a setting, for example, you are the radiographer or the radiologist. Patient asks, "Doctor, how much radiation dose did my daughter receive?" How would you answer? Well, the radiologist or the radiographer will refer to you or to us as a medical physicist for the answer, right? Imagine showing your CTDI is 1.8 milligray or DLP, patient will be lost. So what the clinicians want to know is a simple, clear dose quantities or dose indices, easy to understand, give an indication of risk injury to patients if they're concerned about that, or it's relevant to the patient anatomy, the organ type, and also special cases, young children, pregnant women. Right? So a lot of radiation quantities and unit will be rather confusing. So we need to find a simple way the clinicians will understand, or even the patients. Now, how would you answer, right? It's important for those of us who practice as diagnostic medical physicists. What exposure do you use for an adult PA chest X-ray exam? Do you know offhand? Anyone could just text, put in a chat if you, what's the KV, for example. These are important, right? What's the FFD? Does the patient receive adequate dose to form the image? Is it sufficient or too low? It will be very noisy. Can the radiologist be satisfied with the image quality to make a confident diagnosis? And that is absolutely important. They normally wouldn't quite bothered about the dose. They just want the image quality, because ultimately they are responsible to patient's care. Right? Legally, they are responsible. They need to make the right diagnosis. If the image quality is inadequate, they can't do that. Now, what have we learned earlier in the first lecture, right? Why do we measure patient dose? We know the purpose, right? And how do we measure, the methodology, and also importantly, the scientific basics of radiation dosimetry. Though it is pretty tough, especially the fluence or the basic quantities. But this we need to learn or revise. And I'll continue taking it to the clinical situation. I will focus on general radiography only. That will mean like a chest X-ray, abdomen, pelvic, extremities. Right? We exclude mammography and other pregnant women or young children. That will be another webinar. It's a projection radiography, two-dimension. Right? What we see is a two-dimension image from a three-dimensional out body. The image receptor will be screen film, which is relatively rare now, right? But we move to CR and DDR. Mostly are digital now. And exams, I mentioned chest, abdomen, limb, or skull, I forgot to mention. But a lot of the skull will be taken over by CT. And also it's a fixed position of the body. Right? We don't shift like chest or abdomen. Relatively is lower dose compared to CT, for example. And look at this, is a classic, we do QC on this as well, right? The contrast, noise, detectability. So the important thing is we want to bring the lows down. The dose down means it is noisier, but if the radiologist can detect the lesion, right, the circular is a similar lesion, and this is a process of optimization, right? It's the detectability, and it depends on the clinical situation. Is it a primary diagnosis, or is it give an idea that we just can't do patient dosimetry without image quality assessment. So that brings to this topic of optimization. Will be the theme throughout this webinar. It doesn't, and then for the dose to be minimized without compromising this image quality. Who knows
Okay, I think Prof. Prof, your internet is a bit not stable. Maybe we just lost you. Can you try to share again? And maybe
For now, can you see the screen?
No.
Oh dear. Oh,
Can you share again? And can you, maybe you can switch off your video just to preserve the bandwidth?
okay. How
Try.
about now? Can you see?
It's coming up. Yeah, we can see it.
Okay. Sorry about that. Yeah, I just lost connection. The optimization is important. It doesn't mean we maximize the best, highest contrast, minimum noise while minimizing the patient dose. We need the radiologist to determine the level of image quality that's necessary to make the clinical diagnosis. And it's not the same for every case. It depends what they're looking for, whether it's primary diagnosis or just a follow-up or just a simple fracture. Right? So remember, it doesn't mean the lowest the radiation dose, the better. Oh, is it moving? No. Oh dear.
Try to click your mouse in the slide and move.
Okay. Can you see the next slide? Annals of ICRP?
Correct. We can see that.
Okay. This is the ICRP TG108. This work in progress, almost ready to be published. There are two parts for that. Is on optimization of radiological protection in digital radiology techniques for medical imaging. And the part two is on the practical aspects of optimization of radiological protection in digital radiography, fluoroscopy, and CT. I'm a member of this working group. This interesting. Look out for this TG108, and it has lots of good examples how this patient dosimetry, how the dose will impact on the optimization process. And Dr. Wong mentioned about the IAEA, the TRS-457, a bit of interest on interesting history. We heard about fluorines and all those, right? But these are the basic radiation qualities, quantities, and units. It's all established by the ICRU. These are the very fundamental physics. And then we move on to the clinical, which is all applied. So it is a bit difficult. You find that this 457 isn't the easiest document or code of practice to read. If you compare to the radiotherapy, right? Their TRS, what is it called? 397 or whatever, which is much more easier, right? Can see that there's a lot of issues with the basic sciences as well. So I'll cover a couple of examples related to that. So they have the general radiography. So we have the incident air kerma, and then on the patient, you have incident air kerma, the entrance surface air kerma, which is popularly we call it ESAK, E-S-A-K, and then also the air kerma area product or CAP, or in the old ones among us, we call it DAP, the DAP meter, or now it's called CAP meter. Let's refresh. Dr. Wong explained this clearly. We are looking at want to measure, right? Find out the entrance surface dose, or we call it entrance surface air kerma. And then from software, you can derive organ dose if you want. So let's look at the in vivo patient dosimetry. Is the direct measurement using TLD. When the TRS was written, it's only TLD, but now we have OSLD and other forms. It's a direct measure. We can see that it's measured 100 centimeter. The focus detector distance, right? It's relatively simple to carry out. In the past, TLD is laborious. You need to cool down a new text, right? But OSLD is more like instantaneous. You have the reader, a portable reader in the clinic. You can get the reading and reusable. Is much more neater. But bear in mind, one disadvantage is the uncertainties. Right? The TRS have a lot of chapters on how to handle type 1 error, type 2 error, uncertainty, respect to the detector, the positioning and others. Right? So, and TG191 from AAPM also address this issue, right? That's important to know. And that is close to 30 years ago when we started. This is how we put a TLD strip on the center, right? The posterior part of this volunteer is still screened from time. So TLD, OSLD, need to calibrate it, right? And the TRS has some nice worksheets, and many of these you can download it from the IAGA website. So this is basically the methodology. It's all taken from one thing. To get average, you put 3 TLD in the sachet or 3 OSLD. This for statistical purpose. Right? If you don't have the luxury, just 1 OSLD, at least give you an idea of what kind of entrance surface area. Right? And it called ASAP because when you put it, the detector will receive the back scattered from the patient's body as well. Okay, so that is you can modify that. This is just a recommended method. The other one is measurement, which Dr. Wong also explained that. Now that is the abdomen. You see the particle. This is the iron chamber, the red cow. A bit of history about this CDRH is from the United States Center for Devices for Radiological Health, right? Under the FDA. They started this. I have a chance to work with them. We did some survey on chest, abdomen. It's interesting. So this is to enable the AEC, got those. Well, the TRS is quite particular about correction for temperature and pressure, but in practice, in those of us in diagnosis, we don't quite bother. But in therapy, yes, you need to correct, particularly ion chamber. But today we use solid state detector. That is not an issue anymore. Okay, and the other parameters, the FFD, distance, and all that, right? We also need to have the HVL of the system. So you have an idea of the kind of patient, those from a typical setting. And then we apply the backscattered factor to get the ISA. You can see the geometry here, right? The ion chamber is further away from that. It doesn't detect any backscattered from the phantom. So you have the CDIH, you have the chest, abdomen, right? The abdomen is the lumbar spine. Well, that was delivered by US, so they have US citizen size, but we, as most of us are from Asia, we are smaller size, so be aware. And there people have done some studies, some correction factor to be incorporated. So this was done with a red cow, not that particular red cow was, but today the holder can modify for a solid state chamber, and then that is a PMMA or acrylic with the aluminum as well. Okay? You can see after for the chest. You can still get it commercially. We got it last time is from CDRH FDA. Or you can manufacture. Why? They provide detailed diagram. You can do it in your workshop. There is a good. We had a student, a master project on this. So you can manufacture very low cost. Alternative beside the CDRH that was part of the TRS-457. You have alternative from ICIU Phantom as well. Your PMMA filled with water, a bit troublesome with water in the clinic. You have the NC Phantom as well, okay, PMMA and aluminum. And there are a lot others people have research on. So it's similar. This is just a summary of what is needed for this measurement. So we need to have the AC activated, record, take note of the KV, the grid or any air gap or FFD, the collimation, fuel size, and so on. So this is the close-up view of the CDRH, the Lookout Phantom for chest X-ray. This was used extensively in the US. They call it NEXT survey. This was national cap. A few rounds already. Some countries outside US also have used this for their survey of, because chest is one of the most popular examinations around. Okay, so there is the abdomen survey. So the calculation, if you want to work out, you can have the a simple geometry, inverse square law, and you also can measure the K, which is the kerma, and work out the incidence air kerma. Now notice the notation. This is we follow the ICRU notation, right? Might be quite different from what we normally used to. Early we talked about, well, this one we measure incident air kerma to bring it to realistic situation where you need the backscattered factor built in. So there are tables for those, for different fuel sizes, for different KV, for chest, abdomen. So the backscatter factor is about 1.35, some around there. Okay? So the incidence air kerma multiplied by the backscatter factor will give you the ESAP, the entrance surface air kerma. Right? It is not exact, but in the diagnostic, right, the uncertainty for different parts is so large, but we just want to have an idea what kind of entrance surface air kerma for this modality, for this room, for this type of examination. The other one is indirect method. We have seen earlier, right? We have the CAT meter or the depth meter. Many of the modern digital radiography equipment, they have this. So later I show you a screenshot. We give you the CAT reading, and this can transfer to some of this dose tracking software. It can also relate the tables also to the ESAP as well. So it is a simpler method. So it is good for DRL and you want to do optimization or audit purpose. And that is indirect method. So the other one is just if you know the output, and that'd be good, right? Unfortunately, we still most papers still use the Rangan as output, right? Per MAS at 100 centimeter, they need to convert that. Right? So of course, we need to measure the output, which is quite standard for QC, calibrated dose meter, right? Ruler and others as well. So this is an example how you can measure that, right? Now, don't be frightened by this. I'm still not used to this kind of ICRU notation, unfortunately. The Y is the output, right? In SI is milligray per MAS, right? At a decent D from the tube you measure. This is very standard. Those of you do the QC patient.
Prof. Ng, we cannot hear you. Could
Okay,
you?
sorry. No, I was unmuted a few times. I don't know why. Okay.
No idea. Sorry.
Okay, I'll continue. Okay, I'm right. Another way is to measure the ESAT 20 cm per spec at 100 cm FFD. We assume that 20 cm, right, as the simulating patient's body, and then we use inverse square law to do that. Okay, just take a note. The incidence air coma is what we normally do. It is in if we perform our QC properly, each room, each X-ray equipment will have the high incidence air coma being measured at least once a year, right? So we can use that data. So we know that, and then we can work out, approximate the patient dose. Earlier, I mentioned about the information that is available for those DR system. Look at the top right corner. You have the EI exposure index. Now, this is not patient dose. This is the exposure, or we can call it dose, received by the detector, 0.072 milligray. And you can really convert it to the ESAC if you want. And then the other one is the cap, 0.679. Take note, it's desigray per cm square. Okay, it's a bit quite messy. Different manufacturers, some use centigrade, like in this case desigray. From the cap, this X-ray machine is equipped with the cap meter, so that also is a very good index. Right? So there are lots of information from you can get it from the DICOM header as well. So finally, just cover some factors affecting patient dose. X-ray beam, the KV, higher KV results in lower dose. Added filtration, high added filtration results in lower dose. Now, this is broadly speaking, but there are also exceptions. You need to look at these factors together. Okay? Collimation is important. We need to have a rigorous collimation, right? We just irradiate the necessary organs involved, and the radiographers play a very important role in that, and the grids as well, anti-scatter grid and image receptor. Right? In the past, we deal with film, there's different speed, but today different receptor also have different speed, different sensitivity, also called DQE, and the tube current exposure, the MAS, right? Patient dose is proportional to MAS. And size, obviously we know, right? The bigger the size or thicker, you also have a much larger absorbed dose or ESAP. The last part is the DRL, a bit about that. The ICRP started at 135 DRL in medical imaging. That serve as a standard reference, and then IAEA started activities on that. It is an investigative tool, identify higher dose or lower dose. So it suggests action level you can take to review our methods, how can improve. It's not for regulatory or commercial purpose. Just remember, okay, sometimes it's been misused, right? It's not saying that, oh, you're above, you are, right, not following the regulation. It's not. Right? Neither is it a dose constraint, right? It's not at all. Okay? It's investigative. Its purpose is help us to improve our system and also for optimization. Right? That's important. It started in 1980s and then developed into other modalities in 1990s. It's based on standard phantom, like we talked about earlier, or patient measurements, a lot of measurement, and it's an ongoing activity in many countries, and it's recommended to measure at 75th percentile. I'll show you from the data on the patients or phantom, right? And then it shouldn't be applied to individual patients. It's a collective, right? From that clinic, from the room, from that procedure or the examination. So this is one of the earliest work by NRPB. Now it's called Public Health England. Paul Strimton's work in 1986. This is the pioneer. They were well before the Americans, right? NRPB. They've done a survey from 20 hospitals in England. You can see the wide distribution of entrance surface dose is similar to ISAP if you want per film, right? For chest PA, abdomen AP. Right? So from that, give you, oh, we need to measure patient dose. We need to improve. And this, look at the trend from 85, 95 to 2010. It is the decreasing, right? It's good. Spine, right? Lumbar spine, abdomen, pelvis, all those. It shows that, right, the awareness of the patient dose and how they can improve. Right, we learn the various factors, so they just trigger with these different factors. This part of optimization. And this is the UK survey 2010. You can see how huge national survey, and also the various results they obtain. We in Malaysia are not, we've done this about 1995, is almost 30 years ago, right? One of the very first national dose survey. You published this in the British Journal of Radiology, you can refer to that. Similar trend. This is the entrance surface dose or chest exam. We plot, and also different hospitals on the same chest adult patient, and you see hospital A to K is, and the IA guidance level is, well, IA called guidance level, which is actually BRL at this level, 0.4 milligray. Some hospital are above, some are below. So there's a reason we continue to create awareness and more survey. Now, how to get that is 75th percentile. I would suggest you do a box plot, right? To give you the interquartile range. The 25th percentile is here, Q1, and Q3 is the 70th percentile. This is the one how you get. Let's say you do a survey in one room, 100 patients, you do a box plot, is how you get your DLL for that room. You can do it for the hospital combined and so on as well. So this is a good recommendation from ICRP 135, how you carry out your DLL measurement, right? You collect data, you select your patient size, calculate median dose, right? And then you compare it with the DLL. Of course, you also need to establish your DLL first. Okay? It is more greater, review your technique, exposure setting, equipment performance to QC, right? Consult the radiographers, radiologists, and then optimize, and then you go back. Right? So this is a continuous process. It's not one-off. It's important. I'll give you some example of the DLL. This is from the United States. The adult chest PA with grid is 0.15 milligray. And then you have pediatric, and then abdomen AP is 3.4 milligray. That was published by ACR and AAPM. Oh, by the way, there's another term which we didn't introduce, achievable dose, and this is set at the 50%. Look at the box plot at the middle, okay, 50%. DLL is set at 75th percentile. Okay? So achievable dose means that it is desirable that each center can aim for that to get the acceptable image quality for diagnosis purpose. And this table compares the United States survey, United Kingdom, and Germany as well. There's a lot of ongoing studies, interesting to compare. In some, they are about the same, some vary. For example, abdomen AP, US is 4.5 milligray, UK is 6, and Germany is 10. And by the way, the US survey, they use the CDI's phantom, and on the exposure parameters is not on the patients, Whereas United Kingdom, the survey was done on patients, right? Some slight difference in their approach. Okay, the software, Iris X dose was NRPB, right? Continue with they've done a lot of great work, and that Paul Strimton and David Hart, X dose, and then you have PCXMC from Finland, dose Cal, Kiro UK, Cal dose, and the latest is NCI, the National Cancer Institute from the United States, radiography flows. It's excellent software. It's public available as well. Okay, the standard reference, Medevance phantoms and so on, computational phantom and so on, right? We work out, and there are different software to work out the organ dose. You fit in various exposure parameters, and these are example radiation dose monitoring, the tracking software. There are lots of them. The URL give you, you can look at that, right, from Agfa, Bayer, Canon, GE, and a whole lot of them, Philips, and so you can see and compare. Some are expensive, some are affordable. So take-home points is we need to understand the fundamental radiation dosimetry. Medical exposure requires optimization. There are patient dosimetry, dose monitoring, or dose tracking. There are tools for optimization. I also need to keep track of the advances. We have DR, digital radiography, dose monitoring, audit, IEF audit program, computational, all the models, and of course, artificial intelligence, where there are people working from the images itself, how they can derive patient dose. So thank you very much for listening.
Yes.
I've finished.
Yeah, so then we will move on to Dr. Khalis.
Yeah. Let's see.
Dr. Khalis, are you able to share your slides?
Yes, I'm going to upload now. Okay, can you see right the slides?
It's coming up.
Okay. Okay. Hi, hello everyone. Good afternoon, good morning. So my name is Khalis. I'm from University Putra, Malaysia. First of all, I would like to thank the organizer, AFOMP, and also to our key person today, Prof. Ng, for organizing a thoughtful and wonderful webinar. So I've been given a task to present on the CT dosimetry, and of course I'm going to share also other important aspect in CT dose optimizations. So this is the outline of my presentations, a bit on the medical exposure, and then on the all the CT dose descriptors from the CTDI in air until the effective dose. Of course, the ultimate dosimetry for CT scan is the effective dose. And I'm also going to discuss on the influence of CT acquisition parameters on dosimetry, and a bit discussion on the dose optimizations, because the image quality and dosimetry is correlate to each other. So what is medical exposure? I think this has been presented in detail by Prof. Jenny. So medical exposure pertains the exposure of individuals during the diagnosis and also clinic treatments. So there are basically three important fields covering the medical exposure in radiotherapy, radiology, as well as nuclear medicines. So the term exposure is an indicator of the ability of X-rays, the ionizing radiation, to elicit a specific response in the air, usually denoted as R with units of Coulomb per kilogram. There are two main major radiation sources. We could classify it into two, the background radiations, and also second one is the man-made radiations. So we could see from the man-made radiation, which is majorly from the medical exposure, and 24% of these exposures are from the CT scans. This is from the NCRP report 160. So annually, average annual from the city exposure is about around 1.47 millisievert, which is a second source of exposure to the populations. That's why it's become a concern, especially during in 2007. There's one famous paper published by Brenner and Hall, says that the CT scans may be responsible for increasing the risk of cancer. And therefore, it has become a concern for the populations and everyone's, especially the authorities and all those authorities such as ICRP, ANSIA, and APM, established the various guidelines. And they highlighted the significance of optimizing the radiation exposure from CT scans, especially to the publics. What the most important is to ensure these optimizations are controlled by the CT acquisition parameter without degrading the diagnostic value. Therefore, the most important for us to do the optimization is to assess the dosimetry correctly. So the CT dosimetry, if we assess it right or correct, then we can proceed with the optimizations. But the problem is CT dosimetry is quite complex because CT involve unique geometry. It is exposure from multiple projections in one single rotations, not single rotations, continuous rotations along the z-axis. Therefore, it's not the same as two-dimension projections. It involves 3D distributions of exposure. And CT scan also has numbers of factors that will influence the exposure. I'm also going to discuss a bit on this in the next slides. And also there are variability in the scanning techniques and anatomical exposure. Means by the variability is different manufacturers has different kind of parameters, and also different institutions also they have different. For example, some of institutions for CT brain exposure they use 120 kilovolt, some use 100 kilovolt. So this variability will make governments or the authorities hard to decide which one is the correct one. And with the advancement of CT technology also become much more difficult, much more harder to get an accurate dosimetry profile because of nowadays the introductions of wider cone beam CT, which is actually exceeding the profile exceeding the amount of the length of the ion chamber, which is 100 millimeter. Nowadays, probably the beam is more than the 60 centimeter. That's become an issue in how we can get an accurate dosimetry for wider cone beam CT. And also to get a personal or individualized those calculation for CT is a complex task, because the CT dosimetry actually not represent standard human anatomy. Actually is standardized by a phantom, 16 centimeter diameter and 32 centimeter diameter phantom. But out of all, it's important for us to ensure that we all apply as low as reasonable achievable technique in order to protect and protect and safety of the patients. So the geometry of CT scan is quite different compared to 2D projections. It involves multiple projections where the X-ray beam will enter from all directions during the scan. So we could see that the index of dose distribution in CT are actually slightly the same. So especially when you use high kV or high MS, also they are going to provide more more exposure to the human, to the patients. It is not the same as projection. When we use the high KV techniques, we could estimate that the exposure to the patients become lesser when we use the high KV with the low MAS. So the doses become lesser, but it's not for CT scan. You use the high KV, high MS, all will bring the high dose exposure to the patients. Okay, going back to the history of CT scan. So we all know that CT was invented by the Sir Godfrey Hounsfield in 1971, along with actually they are doing independently the CT scan, but still they share the Nobel Prize in medicine. For medicine is 1979. So from prototype, which took about a minute to produce one single slice of CT scan, we already have seen the CT keep evolving, right? From the prototype, which took longer, and then there are like 4 generations of CT scan. Now I think from single slice and to the multi-slice, from single acquisition technique, axial step-by-step acquisition. Now we have a helical scanning acquisition. So the CT keep evolving and keep producing good image quality, good diagnostic value. I think most of the examinations now consider CT as a gold standard. It's become a gold standard for several diseases. And also with the integration of software, post-processing software, which could extract the vessels, such as in CTA, CT angiography procedure. So we could decrease the chances of invasive interventional radiology by using the CT scan. Therefore, CT has become preferable examinations. It's only comprised about 70% of radiological examinations, but it contributes most highest effective dose, about 49% when compared to other radiological examinations. And this is dose quantities, the basic dose quantities that has been discussed by Prof. Jenny. So we could see that the physical quantities of the external radiations, fluent, gamma, absorb, those actually can be divided into 2, operational quantities and protection quantities. And mainly for the CT dosimetry or clinical dosimetry involving under the protection quantities. We look at the CT absorb of CTDI, which is in gray, and then the effective dose in silver. Before we going in detail on the CT dosimetry, first we need to understand that the CT spectrum is quite different compared to other modalities, because of the CT spectrum is optimized in XY plane using these bow tie filtrations, where this bow tie filtration will filter the CT spectrum and the intensity of the CT photon is high in the center, while in the peripherals is lesser. So this is mimic the human body, habitus of human, and therefore the spectrum is quite different. And also nowadays with the current technology, we have the wide angle of CT beam, also with the integrate technology of Z flying focal spot in order to reduce to increase the beam. So the calculations or the estimations of the CTDI nowadays are a bit different, but we are going to discuss a bit on the basic standard of conventional CT dosimetry. So Schock in 1981 proposed the very first dose matrix. Nowadays we call as a CT dose index. During that time, the CT dose index involved integrations of a finite range from negative infinity to plus infinity. And then following to that, FDA of United States Americas implemented a different approach to this CTDI, where the integrations involved with the nominal slice width from -70 to +70, which actually is 14 slices of dose profile. So integrate all those 14 slices, then they will get this CTDI value. But the problem is the ion chamber that they are measuring is 100 millimeter. So every time when the physicists during that time estimate this dose profile, they are actually giving a report of 100 millimeter slice of 100 millimeter ion beam, the measurement of integration of 100 millimeter beam. And some of the reports using the MSAD, multiple scan average dose. Multiple scan average dose involve several dose profiles, and these dose profiles are averaging. So actually, the difference between MSAD and CTDI is the cover of this radiation profile. For example, the MSAD covering all radiation profiles, and while CTDI focus on the specific length of this profile, which here we are going to focus on the 100 millimeter of ion chamber. The limit of the measurement is based on the 100 millimeter ion chamber. Sorry. So CTDI in air measurement involve a single axial rotation. So we are not using anymore multiple slice, but focus only one single slice, one radiation dose profile, and measure with the 100 millimeter pencil ion chamber. And this ion chamber are placed in along the z-axis of the CT scan. So the very first measurement that we made is CTDI 100, because for the single slice, we integrate the dose profile of from -50 to +50 because of the ion chamber 100 millimeter, and divide with the nominal slice width or slice thickness. And then with the includes of and then in 1998, with the introductions of multiple slice or multi-detector CT scan, probably 4 slice, 16 slice. And then the measurement of CTDI 100 during that time must include with this detector, the numbers of the detector N. So it's what we call as a nominal beam width, along with the integral multiplied with the integral of 100 millimeters ion chamber. And also during after the measurement of CTDI 100, especially in air, we also need to include this measurement of using the phantom, because phantom represent like a human body. So this phantom was introduced by FDA, what we call as a CTDI phantom, made of polymetal metaacrylate. So the size is there are 2 sizes, standard size, which is 16 centimeter diameter, that represent for head adults, and then we have 32 centimeter diameter that represent for body of adults. And when we implemented or entails the measurement using the PMMA phantom, now our CTDI become weighted CTDI. So the weighted CTDI is measured by measuring the 5 different points of CT dose phantom, because there is a center hole and also peripheral hole. There's a 4 peripheral hole, all totals up 5 different points. And then we include the weighting factors in order to derive this weighted CTDI, one third to the center CTDI and 2/3 on the average peripheral CTDI. So what we get is a weighted CTDI value. And this weighted CTDI value actually is good represents of the typical dose distribution in CT scan, because with use of the phantom, we could see the primary beam and scattered radiations included in the measurements. So we could see the dose reductions, especially in the center of CTDI value, center phantom of CTDI value, and it is prominent in CT body phantom due to the Compton scattering effects of the photons. And then with the introductions of helical scanning technique in 2000, led to the quantifications of volume weighted CTDI or CTDI vol. So this CTDI vol accounts for the influence of Gauss translation as well as pitch factor during the irradiations. The CTDI vol basically represents the average dose in the central z-axis region of scan volume and has the same length as the CTDI equations. So the area that is CTDI volume cover is could be defined by the Gauss increment for rotations. So in formula, the CTDI vol is equal to number of tomographic sections multiplied with the nominal width divided with the table translation increment for per axial scan. So to simplify, the CTDI vol is equal to weighted CTDI to the pitch factors. Okay, again, it is important for us to emphasize this, where the CTDI vol and weighted CTDI are not patient dose, it's not represent any patient dose, because they are measured using the standardized phantoms of 16 centimeter and 32 centimeter diameter PMA phantom. Hence, it is important for us to adjust CT dose parameters according to patient size. Because this is the cases that represented in most reports. So APM, TG204, and SURU also has been established this issue. Therefore, this initiative can be applied to compare protocols and make necessary adjustments based on the patient size. So this, I think, this scenario is the famous scenario shown by the most of the slide by the AAPM and also IMES generally. So this scenario involves two types of patients. We have smaller patients, and then we have big patients, larger patients. And both patients, we give a standard parameters, standard acquisition parameters, 120 kilovolt at 200 milliampere seconds. So what we get is both patients receive CTDI vol of 20 milligray. But it is important to note that for the same CTDI vol, the smaller patients actually have a higher dose compared to these larger patients. And then we make some modifications, especially to the smaller patients. Let's say if the smaller patients, we reduce the MAS, the tube current, to 50 MAS. So now we can see that the CTDI vol is reduced by half, which is 10 milligray. And for the larger patient is still the same because of this same acquisition parameter, which gives us 20 milligray. Of this, we can say that the smaller patients already lower the CTDI vol, and it means that the patient dose are approximately equal. But the best measurement for this is to compare it with the other technique we call as a SSDE, size-specific dose estimates, which is introduced by AAPM. Okay, again, this is the ultimate dosimetry for CT, which is dose length product. Again, we need to remember that CTDI, weighted CTDI is measured only from one single axial acquisitions, one rotation only. Same goes to volume CTDI, also measure per slice with consideration of pitch factor. And then we have that dose length product. Dose length product is equal to CTDI vol multiplied with the scan length. And this dose length product is a measure of total radiation exposure for the whole series of measures with the units of milligray centimeter. So the most famous, the dose and product is considered proportional to the scan length, and it is known for use as indicators for several diagnostic reference levels. So usually we can see the report from the console is the results of CTDI volt and also dose length product. And then now we look at because the okay, sorry. So the dosimetry, the other second dosimetry is a size specific dose estimate, also based on the CTDI volt, because dose length product and CTDI volt is not focusing on the meter. Therefore, AAPM 2004 introduced the conversion factors for CTDI for the CTDI volume, to estimate the SSDE, and these conversion factors depend on the effective diameter. So we could calculate the effective diameter from this. We took the length of anterior posterior square plus the length of lateral square, and then square root of all those calculations. From this, we could get the effective diameter. But again, the SSD is not a patient size, but rather the mean dose in the center of scan volume. But recently, AAPM introduced another report on order to improve the accuracy of SSDE, where they introduced a water equivalent diameter as the preferred patient size matrix, because this value will reflect the X-ray attenuations of the patients, and it is a sound descriptor of patient size. And finally, the most important, consider this as an ultimate, the last one, which is effective dose. So with effective dose, we not only can assess the relative risk between the modalities, but also we could estimate the radiation-induced risk. So it is very easy to estimate this effective dose. What do we need is a dose length product and multiply with the K factors. There's a numbers of K factors developed by different authorities. Here I show you on the K factors which taken from the AAPM report 96. Or we also could estimate the effective dose by using the computer software, like previously Prof mentions, using the standard software based on the computational phantom. So for CT scan, we have CT Expo, CT Impact, SCAT, and there are lots to measure the effective dose. So basically, what I present here in the effective dose can be measured just by multiplying dose length product with the K factor. So using the software, we have the computational anthropomorphic phantom. So this computational anthropomorphic phantom represent a human phantom, and they also provide human organ informations, and by using the mathematical simulations. All computational anthropomorphic phantom is based on the depend on the Monte Carlo simulation, Monte Carlo calculations, and of course they are accurate and reliable. There are 3 types of phantom in medical dosimetry. Actually, here you can see it's a mathematical stylized phantom. We also have a demo phantom, and the other one is a standard regular phantom. Now we look at the parameters, the acquisition parameter. For the parameters, we could say that CTDI volume, CTDI vol will be influenced by the acquisition parameters. There are numbers of parameters, but here I present only several that actually will affect the CTDI vol, especially parameter in terms of the scanning mode. The scanning mode, if you're using the helical scan or scan step by step, this will change the CTDI volt. And also the table fit, because table fits are related to pitch factor. Of course, the changes of table fit will affect the CTDI volt. And again, the detector configuration also, when we decrease the beam collimation, especially when we decrease the nominal beam width, of course, will increase the CTDI volt. And again, the other primary factors such as tube current is proportional to the CTDI volt. So I would say that these CT parameters could be classified into three, which influence the CTDI volt. First is the primary factor, then we have secondary factors, and then the other factors is due to the humans. So the primary factors covering tube current, tube voltage, scan time, and pitch factors, and also scan acquisition time. So this primary factor will will influence the CT dosimetry, especially CTDI volt. So we could see that as the tube currents are proportional to the radiation dose, when we increase the tube currents, the dose also, or the CTDI volt, so will be increased. Tube voltage also, the tube voltage proportional to kV square. No, the radiation dose is proportional to kV square. Okay, not the CTDI volt. Sorry. And then the scan time. Scan time also considered as primary factors that will influence the CT dosimetry. So the total scan time will contribute higher radiation dose if a very long time, and therefore it is important for us to minimize the rotation time in order to lower the dose while efficiently capture the signals. Scan time is important because it influences the contrast delivery in CT scan. And finally, the pitch factor. The pitch factor is a ratio of table fit per gantry rotations to nominal width of beam collimations. The pitch factor is inversely proportional to the dose. So when we increase the pitch factor, the dose will be reduced. But using the lower pitch factor, the dose will be increased. So this is a comparison between Malaysia national DRLs. Here we have in Malaysia, which established in 2013. So as observed, the Malaysia and DRLs focusing on the dose length product. They said they focus on the same products, and it is comparable to EU in 1999. But slightly higher to EU 2004 and UK 2005. And we could say that the other regions, especially for abdomens and thorax, the whole those descriptors are comparable. So this is one of my experience in setting up to reduce the CT DRL for CT brain in my institutes, in Institute Cancer Negara. So in 2017, Malaysia set a standard for CT brain dose length product must be below 1050 mg/cm. And during that time, most of the imaging center were within 1150 to 1500 mg/cm. So what do is we actually increase the pitch factor from 0.9 to 1.2, and we could say that the dose length product during that time decreased significantly. So after the decrease, we could see the decrease of this protocol up to 35%. And of course, there are several centers are not happy with the images, because when you increase the pitch factor, the noise spectrums suddenly are very high. So it is important for us to discuss with the doctors or to the physicians which parameters are suited for this in order for us to reduce the dose. And also balance with the image quality. And there are several CT dose reduction techniques. So what can I say? We have the tube current modulation, ATCM. We have the longitudinal modulations covering Z-axis, angular modulation, XY axis, and also the longitudinal angular modulation, which covering XY Z axis. And also we have the organ-based modulations. All these tube current modulations will reduce CTDR volt significantly. And also some of the manufacturers adjusting the tube voltage, and then we have also the post optimizations using the iterative reconstruction algorithm, which reduce the noise after we increase the dose to the patients. We reduce the dose to the patients. Okay, but I'm not going to talk about that. I think I'm feeling taking so long time presenting all this. So I go into summary. So the optimization in CT scan is largely dependent on the scanning parameters and the physical characteristics of the patients. We already talked about the importance of optimizations and the parameters that influence the dose in CT. So it is crucial to consider the CT dosimetry in the process optimization. So like I previously mentioned on Malaysia cases, they want to look at the dose length product. Sometimes other countries are looking into the CTDI volt. It depends on the what type of optimization, what type of CT dosimetry that we want to reduce. And then over time, there have been several modifications in the symmetry measurement, especially with the wide angle cone beam CT and also dual energy CT. I'm sure that these two types of technologies will have a significant impact on the measurement of CT dosimetry. And nowadays, with the applications of AI, I believe that integrations of AI in dose optimization is important. It's part of dose improvement for the future, especially in CT scan. I think that's all from me. Thank you for listening.
Thank you very much, Dr. Muhammad Khalis, for very good overview of the CT dosimetry and able to understand the latest. Okay. Now we have some time for question and answer. There are two questions for Dr. Khalis. Let me see. Dr. Khalis, are you there?
Prof.
Okay. Now, one question is, do you use eye dosimeters during CT angiography procedures? If yes, then what are the exposure or dose noted?
Is it the eye dosimeter for occupationals or for patients?
I think this one refers to patients likely.
Patients. I think this practice is uncommon. Basically, Prof, what do we do is as a physicist, mainly with using the what we call as a simulation or like a study on the the exposure to the using the CT expo, CT impact. We can see the amount of eye lens from those parameters. It's unpractical to use a passive dosimeter put in the eye because sometimes it's make patients will be uncomfort. I don't know. Normally, what if want to measure the personalized dosimeter like this, personalized dose measurement, we are using the computational software.
Okay, that'd be interesting. Any comment from you, Dr. Wong?
Well, we don't do this at our center, as Dr. Khalis mentioned. It can be a bit uncomfortable for the patient, but we have done some work with in angiography, not CT angiography, but the fluoroangiography, where we did measure eye lens dose dose to the eyes using a real-time detector, which we put the detector at the outer canthus as well as on top of the eyelid. In this case, the patient is not awake, so that's probably not too bad. So we were able to measure individual patient eye lens dose, and I think this, if we want to know specifically individual patient, then that's the only way to do it. But otherwise, if you do not have the suitable detector, obviously you can't put ion chamber there. Or if you have access to some passive dosimeter, you can have that, then do that. And yeah, so in terms of what type of dose, not for CT angiography, but when we did with the angiography procedure, we look at some of the more high dose like embolism procedures, aneurysm procedures. They can get quite high, you know, even one of the highest dose are reaching up to more than 1 gray, but yeah, at the eye position.
But Prof, I have another comments. I think because of fluoroscopy involved with the 2D projections, so it is quite significant because the dose can as soon as an entrance surface. But for CT, the problem is CT is a rotational multiple projections. So the problem, it cannot represent as a absorbed dose or especially to the eye lens, because it's involved other secondary radiations and so on.
Okay, thank you. The other question for CT, can a helical scan tracking the patient's surface, like tomography and adaptive radiotherapy, unify the CT dose along with optimizing image quality, like adaptive CT changing MAS and KVP along with patient body? Is there any research on that?
I think our current CT scanner already have this kind of technology. I'm sure that adaptive CTs means by the automated tube current modulations. I think we have this technology. I think most of the more advanced scanners can provide the tube current modulation along with the density of the body. They are changing this MA, but the KVP is not recommended. I don't know. And also it's depend on the budgeting. If it's okay, I think the changes of the MA is already enough to get good quality images, and at the same time reducing the dose to the patients.
Okay, thanks. In fact, now almost any CT scanner you install will have all these modulation, various forms, right? Are very effective. One question: is it possible to measure practically a cumulative dose from different diagnostic procedures to a single patient? Well, the answer is yes, but you have used a different methodology. For example, patient come for a chest X-ray, right? Then can use a traditional, we really do need to measure. We can, from the exposure parameters, we can estimate. And then after that, he might go for a brain scan, CT scan. So again, right, from the scanning parameters, you can work out. Unfortunately, now we really can't mix that together. We are looking at different dose indices. Right? One could be CTTI volume, the other one could be entrance surface air chroma. Right? So we need to look at it from every examination, also from different modality. I understand many people have asked, right, is it possible, right? Chest X-ray, and then later you go for PET scan, and then what is the cumulative dose? Okay, let's see, any other question coming? Do we need to give build-up to OSLD for direct measurement? Dr. Wong, you want to attempt this question?
Okay. In my opinion, for if we are doing it in diagnostic radiology for measuring SR doses and SR, then we do not need to put a build up for that. In radiotherapy, if we want to measure a patient dose, and the idea is similar. It's like you want to do an in vivo measurement. In radiotherapy, if you're not measuring skin dose, then you might want to consider to put in a bolus to measure the dose at a certain depth, like say Dmax or something like that. But in diagnostic, I don't think so. No. I hope that answers the questions.
Yeah, we do need to build up there, right? Not like the top in a Dmax. Okay, another question is it possible to report directly for imaging procedure as regular protocol as we do in radiotherapy? Dr. Wong, you want to attempt this?
Sorry, is it possible to report directly for imaging procedure as regular protocol as we do in radiotherapy? Those reporting. I think the practice is not that common in radiology at the moment. I think in Europe somewhere, some countries in Europe, they are starting this regulation to make sure that there are those reports available for each imaging procedure done. But I mean, in Malaysia, we don't do that because there's no regulation for that. But it is possible, especially if there's regulatory enforcing this, and then you probably would need to install some kind of a dose management software that we've mentioned just now to facilitate this process. Otherwise, to do for each and every patient, that could be not feasible manually. Hope that's yeah. Prof. Do you have anything to add?
Yeah, with the advent of CRDR, it is possible, right? And those reporting system or those tracking, we can export. The information is there. Right? Like I show you the cat meter reading, can go into that. The proponent of this is simply, right, a radiologist will have a chest X-ray down patient. It's like you're prescribing medicine and you need to write down what medicine you're giving. So you're carrying out an X-ray based procedure to have the KVMAS and entrance surface echo or absorb dose, whatever it is, or dose to fetus, for example, for pregnant patient. So this is the rationale for that. But it'll be quite a while before most countries will have that as common as in radiotherapy is different, right? It's require regulatory. All right, let's look at other question. Any more?
There's a question on from Arun Oinam, say that dose optimization require both image quality as well as CTDI. Any method? So I suppose you're trying to ask if there's any existing method on doing dose optimization which consider both image quality as well as CTDI, which Prof. has alluded earlier, that when we do optimization, we have to look at that. Prof. Would you like to attempt that?
And they asked Dr. Kalis, the CT.
Okay, probably it's mean by the how do you correlate the dose image quality as well as CTDI. I'm sure the best to answer this question is the introductions of figure of merits in the calculations. The figure of merit involve quantifications of signal to noise ratio to the CTDI value. I think there's a numbers of techniques which is introduced by Europe experts and also United States experts. They are they includes the figure of merit in their finals decision on in order to correlate the image quality and the value.
Yeah, I think this figure of merit is the one with the latest, right?
Yes.
Method so-called, right? To combine both the image quality and the dose into a single figure, right? To describe that.
While we're
Right.
at that, can I just ask, like, Dr. Khalis,
Yes.
or Profan, that there is no, currently there's still no standard on what is the reference figure of merit value, right?
Yes, yes. I saw some studies done by different groups. Some use signal noise ratio square to the CTDI value, and then some using the CNR, contrast to noise ratio, and there's another group using the SSDE alone to the CTDI volume. So there will be no standards that they try to relate this on the image quality and those using those figure of merit.
I think in one of the early slides that Dr. Khalis mentioned, right? CT is a complex procedure, right? Use of word, and income to the dosimetry is also complex. And it'd be worse with all the new CT modalities coming, right? We have down photon counting CT, right? And all this various form of iteration, right? And then we have the AI, lots of AI embedded algorithms, so it's getting much more complex. And it's good for those of you listening who are interested in research. There are lots of interesting topics to explore. Any other questions? Dr. Rashni, can you, because
Thank you very much, sir. I think we have a few more questions. If you allow, should I take them? Okay. The very first question was, if detector is lead back, is it IAK?
oh, we have tackled all these questions already.
Okay. So I think now we do not have any other questions. So thank you very much, Dr. Kwan, Dr. Khalis, and Dr. Jenny for such a wonderful and interactive session. I think it is already proved to be quite useful for the people, as we have a very less programs on diagnostic procedure, dosimetric procedures. So thank you very much for being with us and providing us such informative presentations. I also want to thank our participants. They are being with us for a very long time on Saturday, and it's a quite successful program today. So at last, I want to thank all of you and want to inform that our next program, AFOMP monthly webinar, will be on 4th of May, and that will be on medical physics contribution to women health and radiation by Professor Hasan Anupama Azari from Bangladesh, and will be moderated by Dr. MD Azhar Mukhtar from Bangladesh as well. So thank you very much for being with us, and the recording of this whole program will be available on AFOMP website, will be within 2 or 3 days, so we can access that. And for the certificates, there is a link in the chat box. You can use that link to provide the feedback and to get the certificates. So thank you very much for being with us.
Take a group photo, Dr. Rashni?
Yes, why not? Sure. Dear all, can you please on your video so that we can have a photograph?
Who's taking the photograph?
Yeah.
You are, okay.
So thank you very much all. So see you soon on 4th of May. Enjoy your holidays.
Thank you.
Thank you.
Bye.
Thank you, Dr. Rashni. Thank you.
Thank you.
Thank you, sir. Thank you, sir.